Good afternoon. Welcome to MTBC's webinar on the 2013 Medicare Physician Fee Schedule. My name is Amrita Dial. I'm the Vice President of Client Relations Management, and I will be presenting this webinar along with Lorraine Getch, MTBC's Vice President of Sales. Before we begin, Lorraine will tell everyone a little bit about the company.
Thanks, Amrita. MTBC was founded in 1999 and currently serves 35 unique medical specialties in 43 states. We have 1,200 plus employees with 24/7 operations. For the past 3 years, we have ranked among the Deloitte Technology Fast 500. For the past 2 years, we have ranked among the Inc. 500 5000. We are a Microsoft and AsureScript certified partner. We also offer a certified cloud and web-based EHR. MTBC also offers its providers a suite of value-added services. For no additional cost, our 5% billing clients use our certified EHR and can sign their patients up for a patient health portal, which is a meaningful use requirement. Our providers save time by using our automated reminder calls, which cuts back on no-shows and saves staff valuable time. Additionally, MTBC offers ADAM patient education, a lab interface, and more.
Thank you for that overview, Lorraine. The 2013 Medicare Physician Fee Schedule was published on November 16, 2012, and includes updated payment policies as well as changes to the Electronic Prescribing Initiative Program and Physician Value-Based Payment Modifier. An additional update from CMS will be published on January 11, 2013, with more information about the status of congressional action to avert the dramatic shift in payments.
Today's webinar will cover the 2013 conversion factor, changes to the relative value units, Medicare telehealth services, primary care and care coordination, payments for new preventative service G-codes, electronic prescribing incentive program, physician value-based payment modifier, and Medicare coverage of Hepatitis B vaccine.
The Centers for Medicare and Medicaid Services projected an increase in payment for providers if Congress eliminates the spending cuts associated with the Sustainable Growth Rate Formula for 2013. Accordingly, any payment increases in the fee schedule, the projected 7% for family practitioners and 3 to 5% for primary care, will occur only if Congress blocks a payment reduction schedule to take effect January 1st as a result of the SGR formula. Of the 7%, 2% stems from the phased-in use of the Physician Practice Information Survey data, and remaining 5% is the CMS estimated impact on family physicians using an assumption that 5.7 million of the transitional care management codes will be billed in 2013.
The SGR, Sustainable Growth Rate Formula, was determined in 1997 and has been postponed every year since then. Due to the enactment of the Temporary Payroll Tax Cut Continuation Act, December 3, 2011, and the Middle Class Tax Relief and Job Creation Act, February 29, 2012, the 2012 conversion factor was $34.04.
CMS estimates that the statutory formula used to determine Medicare physician payments would result in a decrease of 26.5%. Accordingly, if Congress fails to intervene, Medicare payments for physician services for dates of services on or after January 1st, 2013 will result in a conversion factor of approximately $25. If this is not blocked, providers should prepare for a 27% reduction in reimbursement payments coming for the upcoming year.
The AAFP has put together a summary of the 2013 Medicare Physician Schedule, highlighting how various components of the fee schedule will impact primary care and family medicine. They commented that the 2013 fee schedule once again focuses a bright light on the dysfunctional Sustainable Growth Rate Formula on which Medicare payment is based. It reemphasizes the imperative that Congress needs to permanently change the basis for calculating Medicare physician payment.
Since 1992, Medicare has paid physician services based on relative value units for physicians' work, practice, including office rent and personal wages, and malpractice expenses. To calculate the payment for a physician's services, the components of the fee schedule, physician work, practice, and malpractice expenses, are adjusted by Geographic Practice Cost Indices, GPCIs. The GPCIs, which represents the relative cost of the expenses listed above compared to the national average cost of same. Finally, the relative value unit, RVU, is converted to a dollar amount through the application of a conversion factor. The conversion factor for 2013 is $25. For 2013, CMS will begin to incorporate 2 additional specialties utilization data into the practice expense rating. CMS will use proxy practice expense per hour values by crosswalking values from other specialties that furnish similar services. For example, sports medicine will be crosswalked from family medicine, and cardiac electrophysiology will be crosswalked from cardiology. Additionally, CMS finalized a calculation method for the interest rate utilized in computing equipment costs. CMS will use a sliding scale approach based on the current Small Business Administration maximum interest rates for different categories of loan size, which is the price of the equipment, and maturity, which is the useful life of the equipment.
CMS defines an interactive telecommunication system as multimedia communications equipment that includes, at a minimum, audio and video equipment permitting two-way real-time interactive communication between the patient and the practitioner at the distant site. Okay, in 2002, CMS established a process for adding or removing services from the telehealth list. Requests to add services must be received by the end of the year for consideration in the rulemaking cycle. CMS notes that all coverage guidelines specific to the services will continue to apply when services are furnished via telehealth. The National Coverage Determination requires that the service be furnished by a primary care practitioner. The distant site practitioner who furnishes the telehealth service must also qualify as a primary care practitioner under the terms of the National Coverage Determination.
Who can bill for telehealth services? A healthcare professional licensed under state law to deliver the service being furnished via a telecommunication system, including physicians, physician's assistants, nurse practitioners, clinical nurse specialists, nurse midwives, clinical psychologists, clinical social workers, or registered dietitian or registered or nutritional professionals. CMS finalized the proposals to add preventative codes on this slide to the Healthcare Common Procedure Coding Systems for 2013.
The National Coverage Determination process looks for 3 elements when deciding whether to add a preventative service. The guidelines are reasonable and necessary for the prevention or early detection of illness or disability, recommend with a grade of A or B by the U.S. Preventative Services Task Force, and must be appropriate for individuals entitled to benefits under Part A or enrolled under Part B.
Primary care and coordination. CMS states, in recent years, we have recognized primary care and coordination as critical components in achieving better care for individuals, better health for individuals, and reduced expenditure growth. These include Medicare Shared Savings Program, including the Pioneer and Advanced ACO model, Primary Care Incentive Payment Program, Multi-Payer Advanced Primary Care Practice, Federally Qualified Health Center Advanced Primary Care Practice Demonstration, and Comprehensive Primary Care Initiative. CMS discussed that they continue to explore other potential refinements to the physician fee schedule that would appropriately value primary care and care coordination within Medicare's statutory structure for fee-for-service, physician payment, and quality reporting.
CMS noted that the current E&M codes may not reflect all the services and resources required to furnish comprehensive coordinated care management for certain categories of beneficiaries, such as those who are returning to a community setting following discharge from a hospital or skilled nursing facility stay. CMS decided not to restrict billing of the CPT transitional care management codes to established patients, clarification of the post-discharge service period, and their prohibition against billing a discharge day management service on the same day that a required E&M visit is furnished under the CPT TCM codes for the same patient.
CMS will pay for new CPT TCM codes 99495 and 99496 with minor modifications to the code descriptions developed by the AMA's Chronic Care Coordination Workgroup. CMS estimates that physicians or qualified non-physician practitioners would provide the post-discharge transitional care management service for 5.7 million discharges in 2013, though the AMA RUC estimated only 2 million codes would be billed per year.
(2013) CPT TCM 99495. 99495 TCM service with the following required elements: communication, direct contact, telephone or electronic, with the patient and or caregiver within 2 business days of discharge. Medical decision making of at least moderate complexity, intra-service time 40 minutes during the service period, and face-to-face visit within 14 calendar days of discharge. Assuming that Congress blocks the payment cut, CPT code 99495, when CPT 99495 is performed in a facility, the reimbursement is approximately $135. In a non-facility setting, it's approximately $164.
For the Transitional Care Management CPT code 99496, the following must be performed: communication, direct contact, telephone, electronic, with the patient and or caregiver within 2 business days of discharge, medical decision making of high complexity, which is intra-service time 50 minutes during the service period, face-to-face visit within 7 calendar days of discharge. Assuming that Congress blocks the payment cut, for performing a 99496 in facility, the reimbursement rate is $197.76. In a non-facility, it's $231.12. Nevertheless, specialists who furnish CMS estimates primary care physicians are expected to bill the TCM codes most frequently. Nevertheless, specialists who furnish the requisite service in the code descriptions may also bill the new TCM codes. As for non-physicians, qualified healthcare professionals, CMS believes only NPs, PAs, CNSs, and certified nurse midwives, CNMs, can furnish the full range of E&M services and complete medical management of a patient under their Medicare benefit to the limit of their state scope of practice.
CMS finalized 2 additional exemptions for participating in the Electronic Prescribing Incentive Program. The 2 additional exemptions include eligible professionals or group practices that achieve meaningful use during certain prescription adjustment reporting periods, and eligible professionals or group practices that demonstrate intent to participate in the Electronic Health Record Incentive Program and adoption of EHR technology. CMS will begin covering hepatitis B vaccine and its administration to all individuals diagnosed with diabetes mellitus. As we come to a close, I think we have time for a question. So the first question is, I'm a solo practitioner. Do I need to worry about the physician value-based payment?
That's a great question. CMS will begin gradually phasing in the value-based payment modifier initiative. So that means for this provider now, they'll use 2013 data to determine payments for 2015. The value-based modifier will initially apply to groups of physicians with 100 or more eligible professionals. CMS initially proposed applying the modifier to groups of 25 or more providers. So at this point, the solo practitioner does not need to worry about the physician value-based payment.
All right, thanks, Amrita. We've included some helpful links on this page if you'd like to learn more about the 2013 fee schedule.
Thank you, Lorraine, and thank you everyone for attending this webinar.